I think we'll go ahead and get started. I think I've got my machine to cooperate at the moment. So thank you for your patience. So I am Eileen Doherty, and I am the director of the Colorado Gerontological Society. And today, as part of our Advanced Care Planning series, we're going to talk a little bit about the MOST form, which is technically known as Medical Orders for Scope of Treatment. And where this really comes into play, if you will, is as we are faced, if you will, with decisions about what type of care do we want, and at what point in our life do we want all care that's available to continue? And is there a point in our lives at which point we would feel better if we focused more on comfort care as opposed to full treatment?
So, what I thought I would do today is talk mostly about this form and then the implications for this form. So, this form is called the Colorado Medical Orders for Scope of Treatment, or the MOST form. What you may see in other states is sometimes it's called a POST form, POST, instead of a MOST form, which stands for Physician Orders for Scope of Treatment. When Colorado put this into effect about 15 years ago now, one of the things that we struggled a lot with was how to have something that's very identifiable, as well as how to get it adopted by healthcare institutions. So the first decision that was made by the group is that it would be printed on Vulcan green or Terra green paper. This, if you have for a frame of reference, sometimes we can also see this as the Astro Bright greens that you get like at Office Depot, or it's just really a bright green. It's not a grass green, but more of a sun green, if you will. Now, just because the original idea was that it should be printed on green paper does not mean that if you sign one and it's not on green paper, that it is invalid. So therefore, at some point later, we had to go back into the legislature and get them to agree that both copies as well as any other colored paper or even white paper was absolutely legal. Part of what happened initially is that as this piece of paper, which was supposed to be transferred between institutions and always stay with the individual, was getting lost, and the purpose of it was not was lost then because we didn't have the original. And so now if you are in, say, a nursing home and you are transferred to the hospital and you have a MOST form, they most likely will actually send a copy rather than the original. So the initial instructions for treating providers is that basically this usually is sort of seen as an initial point of contact for emergency responders. So if you have a MOST form, and if the ambulance or the fire department or the police department are called and this is presented by either you or your family members or other members in a facility where you might be living, the instructions to the EMS people are simply follow the orders. After they have followed the orders, meaning if you want to be resuscitated, then after, and they have issues or questions, then their instructions are to call the physician, the advanced practice nurse, or the PA. These orders definitely are supposed to reflect your personal decisions and your conditions, your wishes. There are 4 sections to it. If section A and B are not completed, then the assumption is that you want full treatment. You have to be 18 years of age to initiate one of these, and people should always be treated with dignity and respect. So to start this process, basically, we have the verifying information over here on the right, which is your name, address, date of birth, sex, hair color, eye color, and race and ethnicity. Now, sometimes I get asked the question, do I need a MOST form if I have a medical durable power of attorney? And some of you may have joined us last month when we covered the medical durable power of attorney. And the answer is that this document has some overlap with a medical power of attorney. The medical power of attorney can function independently. The MOST form, what it does is it provides a medical order or a physician's order for care that you want. A medical power of attorney simply says to an agent, this is what I want you to do when I need this type of care. So if you want your agent to always be making those decisions for you, then a medical power of attorney is sufficient. If you want to strengthen that with some physician's orders, then go ahead and fill out a MOST form. There are 3 basic decision points on this medical power of attorney. 1 is, do you want CPR? 2 is, what kind of treatment or medical intervention do you want? And the 3rd section is, what do you want in the way of artificially administered nutrition? And we will take each one of these sections separately. So the first question in part A is, do you want CPR? And because I was very involved in the development of this form, one of the things that we agreed upon right up front is that CPR, in terms of patient education and sharing it, making sure that older adults or anyone who initiates one of these, that they understand that you are asking for care if you have no pulse and you are not breathing. So that is what CPR does. So yes, I do want it. So I want you to attempt to resuscitate me, or no, I do not want to be resuscitated. So there's a little note here then that says, if you do want CPR, then you also in section B need to select full treatment, because if these two are not in agreement with each other, then again, the EMS people, the ambulance attendants, they are going to err on the side of attempting to resuscitate you, even if that is not what you maybe initially wanted. Also, if you fill out, in addition to a medical power of attorney asking your agent to speak for you, and you also fill out a DNR or a do not resuscitate order, then again, this document, the MOST document, should be consistent with your DNR, so that if you do want resuscitation, it says that in all 3 places. If you don't, then it should say that in all 3 places as well. So this is just to make sure that sometimes these documents do not get filled out at the same time. So if you fill out a MOST form, or you're acting as an agent for someone, make sure that you also look to see whether or not they have a DNR, and if they do, make sure that they are consistent. So this is part B, or the medical intervention, the treatment portion of this form. So again, we just want to make sure that you understand if you that you have a pulse and you are breathing when we make this decision. So the previous one, you do not have a pulse and you're not breathing, and this one, you still have, if you will, life. So now we have 3 choices, if you will. We can choose full treatment, where our goal is that we want to continue life using all medical procedures that are known to the medical profession. So this can include such things as intubation, advanced airway intervention, mechanical ventilations, CPR, any of those kinds of things. And if in fact medical personnel do initiate this level of full treatment, They are always instructed, even if you as the individual say, I do not want to go to the hospital, or if your agent says that you do not want to go to the hospital, they are usually required to transfer you to the hospital. And usually, if they have initiated any of these types of procedures, you will be immediately admitted to the intensive care, because this is a very high level of care, requires a very skilled group of people to provide those services. If you're kind of on the fence and you say, well, I don't know if I want everything, you might decide to select selective treatment, or the second one. And in this one, you might want to have some level of treatment, but you may not want all of the treatment that would be provided under the full treatment. So again, we may focus on comfort care, but we might use just antibiotics, IV fluids. We don't want to be intubated. We don't want to be put on a ventilator. Usually, this will also require a transfer to the hospital, but it may avoid intensive care. Again, it really depends on how sick you are when you present in the emergency room. The third option that we have is comfort-focused care. And really the goal here is to relieve pain and suffering with any type of medication that we have. We're going to use oxygen. We may suction out the lungs, suction out the airways. Again, we don't want people to aspirate and get a whole bunch of gunk in or food in their lungs. We may suction out their eustachian tube, or their breathing tubes, those kinds of things. But we're going to do that manually. We're not going to be doing that with any type of fancy equipment. We're also going to avoid any treatment that we might have initiated under selective and full treatment. And oftentimes when somebody chooses comfort-focused treatment, they may or may not be transferred to the hospital. If they are transferred, they would not receive any type of life-sustaining treatment, but only receive comfort care. And again, they may be transferred to a hospital even with this, say if you were in an assisted living facility, because it's outside of their scope of practice, most likely for the level of care that you would need. Or you may be in your own home and you may not have any family members who could help you. And if that was the case, then obviously they couldn't leave you in your own home, even though they were only providing comfort care. So at that point, they would make the decision to transfer to a hospital. In terms of administering then life-saving procedures, that is, what we just discussed. Now, as I said earlier, that we have reviewed A and B, what this just simply says is that if A and B are not completed, then we are going to proceed with full treatment, basically. So this is just a little bit of a review. So medical orders for treatment, primarily, as I said, focus on emergency personnel, but they can also be focused on healthcare providers as well as healthcare facilities. In Colorado, most of the healthcare facilities, such as assisted livings, nursing homes, memory care facilities, sometimes hospitals, personal care boarding homes, a lot of times the community center homes, a lot of them do have the MOST form as one of the documents that they will have you sign upon admission. And they often then will also review that as your care conference time comes up to see whether there are any other changes that you or your agent would like to change on your original form that you executed. The important thing to know here is that the healthcare provider is required to follow these medical orders. Now, where sometimes we get into a little bit of a dilemma is that a facility like a nursing home or an assisted living, they do not have the authority, if you will, as the staff in those buildings to actually follow or execute the MOST form. That has to be done by a healthcare provider, usually a physician, an adult nurse practitioner, or a physician's assistant. So the MOST form, the facility staff, even though they know you have a MOST form, and it might say that you want comfort care, if you go into some type of arrest or you need some level of care, the facility is required to call 911 or emergency personnel. And then emergency personnel, then as in a facility, if they are presented with a MOST form, then they can contact the provider about following those medical orders. Another thing that we had to deal with in terms of putting this together was we had to make sure that any healthcare provider, and again, this is the doc, the nurse practitioner, or the PA, are immune from any type of civil or criminal prosecution. Where there is, again, risk is that if the facility, rather than the healthcare provider, believes that it is their responsibility to start to implement the MOST form. And again, sometimes I hear family members being very upset because the facility contacted EMS rather than the provider. So again, one of the things that you can do as you are working with facility providers is instruct them that if my mom goes into, say, distress, not necessarily cardiac arrest, but distress, call the healthcare provider first rather than calling EMS. Now, if it's in a really emergency situation, they do need to call EMS right away and then make the decision about the treatment as a secondary decision point. Again, if you have a medical power of attorney and we have initiated any type of extraordinary care, we can always discontinue it using a medical power of attorney. If for some reason the healthcare provider feels that they are not able to follow the orders, then they do have an obligation to actually refer you to another provider who is able to do that. Just a little bit on comfort care. So if you check comfort care, that is as mandatory as the other two. And then the option on the form says, can you tolerate oral fluids and nutrition? Again, if comfort care is checked, the suggestion is that once you get to that point, that you consider seriously working with hospice and palliative care and checking whether or not that is the type of care that you would like to receive. So this is the box on the form that you would basically check for nutrition. So artificially administered nutrition, and again, this always provides for offering food and water by mouth if feasible. So no feeding tubes, just by mouth, or and you could do water or food. Any legal decision-making, like a medical power of attorney, a healthcare proxy, guardian, or other, must also follow the directions if there is a living will. If there's not a living will, then again, we make the best decision we know how to do. A healthcare proxy does not necessarily have the authority to fill out a MOST form, but a medical power of attorney does. So then again, we have three choices. Do we want artificial nutrition by tube and permanent if so indicated, short-term or temporary? Or do we want no artificial nutrition by tube? So even if we checked by tube, the third option, they still would offer food and water. So now we're getting ready to continue on for the next section of completing the form. And like I say, it should be printed on this Vulcan green paper. Does need to be signed by the physician or the healthcare provider and their name and contact. You can do verbal orders that can be valid for 30 days. I highly recommend against that, simply because that is good. It works if there's like a wife or a husband providing care in the home. But if you are in a facility, that's not going to be a very good option. And it isn't because you've got the changeover in staff, etc. A very important thing is to make sure that your preferences and your medical indications really guide how you complete the form. And as you change it, as your condition changes, it is perfectly fine to initiate or make a new one. I do suggest that if you have one and you say get metastatic stage 4 cancer, and you've also got some other very critical health issues, and you had a lesser treatment or interventions, and now you've decided that you want to discontinue all treatment, it's better to void the first one rather than to try to amend it. Amending it gives us the opportunity for mistakes to be made and for your wishes to not be followed. For as much as possible, we always want to include the patient in that decision making. And again, many times when I have been involved in these situations, the patient or the resident was really not able to make that decision. But as I indicated last in the medical power of attorney discussion, this is where I believe it's absolutely critical to have those very one-to-one frank decisions so that I understand if I'm taking action that I am following your wishes. As I said a few minutes ago, a healthcare proxy cannot decline artificial nutrition and hydration unless the physician and a neurologist certify that hydration and nutrition only prolong the act of dying. So this is the part of the box that basically we indicate who was involved in making that decision. So again, we check the correct boxes. Then we get to the next section, which is the section for who signs it, whether it's the patient, the provider, the physician, the guardian. So again, making sure that we all know, oftentimes these decisions are non-reversible. So if, for example, in section A, you said you do not want CPR, and understanding that at that point you have no pulse, and you are not breathing, then we cannot reverse that if you check no CPR. So just, we want to make sure you understand as you sign these documents, or that your agent understands what it is that they are signing. Again, it's repeated then here, to the extent that previously completed advance directives do not conflict with the medical orders for scope of treatment, they shall remain in full force and effect. So again, this is the part that says if the doctor or the healthcare provider signs, as well as the patient or the decision maker, that we are signing the most current form and that this is an order, and that is what we want to happen. This is signing the form then when you're transferred. This oftentimes is a section that may or may not be filled out, because otherwise, if you have multiple trips to the facility, you may or may not get it transferred. When I have seen this section filled out is when you leave one level of care for the next. So saying you've been in an assisted living, you now are no longer able to return, then this form gets filled out when you are transferred to a skilled nursing facility. As with all advanced care documents, we suggest that you always review them. They should be reviewed regularly by the healthcare provider or facility staff with the patient or the decision making. It should be done on admission or discharge, and then if there's any substantial change in healthcare status or treatment preferences, or if there's a change in the legal decision making, or even if there's a change in the physician, because again, we have put the physician's name and telephone number and contact on there. And so if EMS has to get in contact with them, we want them to be able to contact the right provider. This is just again, documentation of when it has been reviewed and whether we've completed a new form or whether the current form stands. So just reviewing again, if you do a new MOST form, when you have substantive changes, whether that's change in your condition, change in your doc, a change in your legal representative, any of those kinds of things, then draw a line through sections A through C of the original and write void on it. And then there's not really a name or place provided, but just sign your name and date it so we know that that one is voided. So if there's any question, we have that place. The form is HIPAA compliant, but it also is under the rules of HIPAA. It can be disclosed, the information can be disclosed to other healthcare professionals as necessary. Okay, I'll have to fix this link, but basically this was a link to help to provide some resources about where to get the form. So we have a copy of it on our website, and this link here to the Colorado Gerontological Society will take you to that section. The actual MOST form is maintained, and some of the data, by the Center for Improving Value in Healthcare, or CIVIC, and that's a link to their website. We also have a couple of videos on our YouTube site that you can use for reference, as well as excuse me, the Colorado Advanced Directives Consortium. So I will fix this link before I send it out. And that concludes our conversation at this point in time on the MOST form. Just quickly, this is a list of some of the programs that the Society offers. You are welcome to contact us if you have more questions or check this out on our website. These are some additional programs that we offer as well. And we always invite you to join us for those programs.
Well,
thank you for joining us. And at this point in time, I will check the chat and take any questions that you have. So it looks like no one has put any questions in the chat. So if anyone has any questions that you would like to ask at this point in time, I would be happy to entertain those.
Hi, Eileen, it's Jan with Blossoms. And I just want to thank you for this refresher reminder. Obviously in my space, I run across this a lot, and I don't think people have a current picture of what this needs to look like and additional conversations. So I think it's really important.
Okay, great. Thank you. Question was put in the chat. Do these forms expire after a certain period of time? No, not at this point in time. Okay, seeing no further questions then, thank you all for joining us today. And our next session in the Advanced Care Planning series will be on National Healthcare Decisions Day. So we'll be off a little bit in terms of this rotation, but it will be on April the 16th, 2025, and it will be from 12 to 1 again. And so we'll be talking about kind of general things, but to amplify and sort of get the word out, if you will, about National Healthcare Decisions Day, I always like to do a session on that day, just giving, again, more visibility to the need for advanced care planning. So thank you all, and I will see you soon.